Hey, everybody. It's so exciting to see you again. Kevin and Donna back for another really exciting episode of the Deprescribing show. This one, mechanical falls. So it was really interesting when mechanical fall was used. I said, Donna, you're going to have to remind me what mechanical fall is. So I even just plugged into the terms of what those are. And the funny thing is, mechanical falls, I wonder how often, Donna, they are actually a mechanical fall. We'll talk about that and a little bit more in this exciting episode. So mechanical fall, you know what came to my mind first, Donna? Like I was like, does that mean like someone has an apparatus or are we doing robotics related to a mechanical fall? Like what is going on that is a mechanism that is causing
Oh,
a fall?
so funny, right?
But interesting, like in a risk evaluation or a fall score,
Yeah.
that's something we're evaluating the room and the home for in an occupational, therapy walkthrough. Um, but when we're talking about it from a pharmacy perspective, usually you and I are always trying to think, what is the actual root cause of this? And so doing a lot of RCAs on falls, I know that oftentimes those drugs are to blame, Donna, but you have a really cool patient case for us, I know, to unwrap. Any other things that we need to talk about before we jump in?
I think it's important that we know, not every fall is all these red flags and sirens and everything else. They can be pretty benign, it looks like on paper. And then as you go through the process, that's when you really see the interesting, intricate sides of the twists of a fall.
Yeah, I mean that's so interesting that you. I mean, even when we were texting back and forth, it was like, this isn't really a big case. It's like red flags and sirens and all kinds of things going on.
Right.
It's interesting how simple like things can start that end up leading to a fall. And even thinking about like not even patient cases, but family cases of family members falling, in the past was
Yeah.
something that seemed rather benign. Like I just started using this medication for this and had no idea it was related to me having any issues with fall, or the
Right.
patient didn't even have a history of having any cardiovascular problems or mobility
Mhm.
issues or anything. And all of a sudden
Right.
a new med is started. And we didn't realize it was for anything other than their blood pressure control because, uncle, aunt, grandma noticed that
Right.
they were getting above the 130 mark. And so something had to be
Mhm.
added on board. But no,
Yeah.
I love you highlight that. Let
Yeah.
me share my screen, Donna, so you can take it away. All right.
And so Kevin, just talking about the twists and turns of a fall case, and I have it here because we always get like all raveled up, right? And in all these things that we're taking, you can almost think that each little ribbon is a medication, right? That just kind of gets involved with other things, and then before you know it, we're twisting and falling. So, just really thinking about our the age of the folks and what they're taking and that polypharmacy number, things that we have been talking about right along. So looking at this case, the medications don't seem alarming, really. The most alarming thing is probably the oxycodone, and that's because they're on it in the hospital now because of the pain that they're experiencing from the fall, but they weren't on that previously.
Right.
And then also the lidocaine patches were also not on previously. But if we're thinking about this, we're looking like, okay, all right, calcium, sure. A lot of older folks, if we suggest calcium and vitamin D, and all right, they're on metformin, not a huge dose, and the B12 probably been on it for some time. Great that they do the B12 instead of throwing on the gabapentin. So those are great things that we're seeing here. And then you go down a little bit more and you're looking at, eye drops for allergies. Okay, maybe there's some issues with vision or itchy eyes or something like that. And there's also loratadine. So it's a second generation antihistamine. So that would be favorable for the patient too.
Right.
Um, we have a couple of different cholesterol medications, the fenofibrate and atorvastatin. So that might raise a little bit of a question, why are they on both? How long have they been on both? What could possibly be the issues? What's their lipid panel actually like now?
Mhm.
Lisinopril, kind of a higher dose, but maybe necessary. It's not like there's a million blood pressure medications that are on there. So, okay, not terrible.
Okay.
Omeprazole, you start wondering how long have they been on this for and maybe what might be going on there. Hydrochlorothiazide, and again, we have to be worried about those electrolytes and what might be happening there. And of course, I said like oxycodone, she's now taking it because she's in the hospital after a fall. So, looking at this, maybe a couple of question marks, but not horrible, not anything that we would be like, oh my gosh, this is terrible. Your anticholinergic burden is out of control or anything like that. So it really is the number of medicines that you start to question.
Yeah, I
So,
love that you
yeah.
say that, Don, because this looks like 80% of the long-term care individuals
Mhm.
med list that you're going to see, or most geriatric folks.
Yeah, for sure. So then, as we're going through this, the reason why I wanted to go through this case is, um, it has come up a couple of times. Like, how do I look at a case, right? How does a pharmacist look through a case, and what causes the red flag? So I see that this patient is in the hospital due to a fall. So right there and then, I am interested. And then I see this multiple cascade of medications that this person has been on, and now I start thinking about the disease states, and I start looking at, as I look at the medications, I want to make certain that they have particular disease states that make sense. I think like, all right, metformin should have type 2 diabetes on their case list. So sure enough, type 2 diabetes, hyperlipidemia, hypertension, history of DVT. So that is a little bit of a question mark because I can't find a date of the DVT. You know what? I'm sorry. I should have a Pixaban on this, and I thought I did. The patient is also on a Pixaban, 5 milligrams
Okay.
twice a day.
All right.
Sorry about that. So now that we are, looking at this, there's this history of DVT. So there's a concern the patient fell, a bleed, potential. So there is concern about that. GERD is omeprazole, why they on this, and she has GERD. And then the seasonal allergies. But you know what? You're looking for that, but really there's nothing on the record that actually says anything about allergies other than a couple of medication allergies, and that's it. So
Okay.
don't quite understand if it is like a seasonal allergy, if she really needs these medicines, if she just continues to take them, and it's not necessary this time of year where it might be more in the springtime. So that could be something to consider too. So I cannot find any reason at all why these allergy meds are on board.
Hmm.
So now we get into the findings a little bit. So we can match up the majority of medicines, but not everything. So
Right.
now we start like looking through the chart, and what's going on with this person and what do we know about this person. So this is, I didn't, I just wanted to kind of give a bird's eye view as to the approach that I take. So of course there's much more that goes on when you're looking through the charts, but basically I want to know a little bit more about this patient. An 88-year-old female. She fell, she hit her face, her ear, her shoulder, and she'd never had a fall like this ever before. So,
Mhm.
like, well, all right, 88 years old, haven't had a terrible fall. That's wonderful. But we still have polypharmacy here. It's still an issue. And yes, she might have been on a frailty score of maybe around, say, 2 or 3, somewhere in there. Not quite running marathons, but being able to ambulate and get around. So, does live with her daughter. So maybe might need a little bit of help with some daily activities, but nothing substantial is mentioned. Um, so you're like, okay, wow, this is kind of interesting. And then you go in a little bit more and you find that this fall did not lead to any fractures at all. So that's good. Um, she has low magnesium, low sodium. Her hemoglobin A1C is at 6. That is super wonderful for someone 88 that has type 2 diabetes. So there's probably
Mm,
been some changes throughout the years, and
mhm,
is treatment still necessary? And then her lipid profiles isn't horrible. She has a total cholesterol of 180. um, Her triglycerides are somewhat elevated, but not terribly, 199. So not terrible, nothing that would be alarming that we would have to treat at 199. Anything over like 150, of course, is high, but we don't typically treat unless we see higher numbers, 400s or 500s in there. Her HDL is a little bit on the lower side. It's 42.
mm.
So more or less borderline, not fantastic. But we're going to get into that. And her LDL is 102. Not terrible. She doesn't have any history of a previous cardiovascular event. So it's not like we have to be at 70 necessarily for the guidelines. So not horrible. And um, still, just kind of questioning things. Do we really need all this medicine on board for her lipids? So
Right.
looking into that, we then want to be thinking about, all right, so we kind of have the things we want to be looking at. So these are our findings just in general as we go through the chart. And now we want to think about the patient issues and side effects. She feels like she's not as strong. She feels weaker than she used to. She feels like she has muscle weakness. Her heart rate is increased. We see that in the chart. It's in the higher 90s, but again, she just fell, could be anxious about what's going on, in pain. So if it is, more elevated, not anything that we want to necessarily treat immediately, but definitely want to consider, keep an eye on, and see if this is an issue. We see that there is polypharmacy, of course, and she also came in dehydrated. So that was an issue for this patient. Um, and so we're thinking about, okay, the diuretic and what was going on. So in the notes, she was supposed to be taking hydrochlorothiazide 12.5 milligrams on an as needed basis, but instead she was taking it on a daily basis. Not quite certain when that changed, but there was, maybe some miscommunication that might have occurred, or it could be that she was just taking it inappropriately all of a sudden, like just all of a sudden decide, oh, I should take this. I have it. I should be taking it every day. Who knows what was going on there? So, but anyways, there was a change in how she was taking the hydrochlorothiazide, and it did not match the instructions on the prescription.
Okay.
So, um, so now we kind of get into more of the sleuthing, and we're thinking about, okay, here we have all of our findings for the patient, right? And then also what the patient is telling us. And we kind of sleuth things through a little bit more. This is my most favorite part of deprescribing, I must admit, is the trying to figure things out and, coming up with the story of what could potentially be going on here. So I just love this part, and being able just to think through medications, potential side effects, um, interactions, everything that could possibly be. So when we're looking at fenofibrate, I really wanted to look this up first because it's not really a go-to med any longer. It might have been years ago when perhaps she did have a cholesterol issue, high triglycerides. So I saw that she was on this back in, 10 plus years ago. So now it's continued, right? And we see it just being continued on. It's everything's good, no problem. But fenofibrate over time, it can decrease HDL. That can happen as quick as 2 weeks time, but it can also happen indefinitely throughout the course of treatment. So where her HDL is on the slightly lower side, maybe the atorvastatin doesn't have that option, if you will, to really increase the HDL like we see statins do. So that is a little bit questionable in regards to maybe that interaction or effect that might be going on with the HDL. We are cautioned in the drug monographs that we need to use fenofibrates with caution. In our older adults, we want to definitely use a lowest dose for these patients, and we just have to be very careful because of muscle weakness. That tends to be an issue with fenofibrates. So therefore, we're thinking about over time. There could be a change over time that we don't notice because it's small and incremental as somebody's taking medicines throughout time. So maybe there has been a change in muscle strength, and it could have had a long-term effect over time. So that's, something to be thinking about. We already talked about the blood, the not the blood pressure, I'm sorry, the pulse is the beats per minute is in the 90s. So we still want to kind of be looking at that a little bit more, not quite certain what could be going on there.
Yeah.
We don't know the reason for the allergy meds. The time frame for the DVT is unknown. So was it a provoked DVT? Was it unprovoked? Has it been over 3 or 6 months since treatment has occurred? Is there really a need for this continued treatment? If she's fallen once, perhaps can fall again, most likely, or more likely, it increases the risk of falls. So we want to make certain that we're not keeping on apixaban indefinitely beyond its need, in just to make certain that we don't have an increased risk of bleed for this patient if they were to fall again. There's this chronic use of proton pump inhibitors, which of course could reduce the metformin. I'm sorry, I take that back. The magnesium, excuse me. um, so the PPIs can reduce the effect, can reduce magnesium levels. It can also cause changes in B12, but this particular patient has had low magnesium levels, so it could very well be that the proton pump inhibitor is part of that. Remember too that she increased the hydrochlorothiazide on her own, and that can also reduce magnesium levels. So maybe a combination of the both, especially if she was borderline anyways. Magnesium, as we know, can also cause low deficiency in magnesium can cause muscle weakness. So all of that could definitely be part of the issue. And then metformin may no longer be necessary. Her blood sugars have been excellent for a type 2 diabetic. They've been around 100, maybe 120 tops. So not alarming at all. Her hemoglobin A1C is at 6. So that is extremely low for an older adult. That someone who's 88 will allow up to a hemoglobin A1C of 8 and not be too overly concerned. So something that we can most likely reduce and monitor and check on. So, and then hopefully eventually stop even. So now that we've done the sleuthing, we start thinking about, okay, let's look at the meds again and let's see what we might be able to recommend. What could we perhaps deprescribe? So when we're thinking a little bit more about this, I didn't list everything as I did here in red, but the calcium isn't always the friendliest to someone's stomach, and we don't really know how she's doing with that. I know she complains about GERD, but does she have other stomach issues, other discomfort? Maybe the calcium isn't helping out her stomach symptoms. So it might be something we could potentially consider stopping. Metformin, we know the hemoglobin A1C is excellent. So probably do not need this any longer. It would also, if her B12 was low, it would also potentially reduce that deficiency over time. However, she was taking B12 and I could not find a B12 level in her chart, so not certain who decided to do that. For the lidocaine patch, she's using it currently for pain, but we certainly don't want to keep that on indefinitely, so something to monitor. The vitamin D is appropriate. She's had a chronic low vitamin D. We could almost increase this for this patient, so that might be something to look at. The vitamin B12, if we stop the metformin and the omeprazole, that could eventually not be necessary any longer. The Tylenol is needed for pain right now. Fenofibrate, I would definitely consider stopping and monitoring the lipid panels, especially triglycerides. But I definitely think that providing less chance of muscle weakness or furthering muscle weakness would be appropriate. Loratadine is not necessarily appropriate for the patient or the ketotifen because she's not complaining of allergies. There doesn't seem to be an allergy issue. So just maybe it just needs to be a seasonal use versus chronic use.
Nice.
Atorvastatin I'd keep on. Lisinopril I would keep on at this point. Omeprazole, a slow taper off, but definitely could be of benefit for the patient. And to stop the hydrochlorothiazide altogether because of the low magnesium, low sodium, and the dehydration that she was up against. So those are things that we could absolutely stop. And then oxycodone just as necessary right now to help her with that fall and the pain resulting from that, but certainly not to keep that on long and try to switch over to just Tylenol as much as we possibly can. So like a lot of steps, right? A lot of things to be looking at. And if you look at the list of what remains, it's basically cut in half. And that's the exciting part of deprescribing for me. Is just to see what can ensue here in regards to what's left kind of thing. So pretty wonderful to see this. And really after this pain episode diminishes, there won't be much left on anyways. So
Right.
things that we want to monitor if we make these changes, of course, our magnesium levels and sodium levels, and keep checking on those. We want to see how her GI tract is doing in regards to acidity, talking about diet changes and being kind to the stomach with what you're eating, choosing to eat, thinking about amounts of caffeine or acidic foods might need to be taken into consideration. We want to, of course, be checking blood glucose levels and hemoglobin A1C as we take the metformin off. The cholesterol panel and triglycerides for reducing or stopping the fenofibrate. And then, of course, blood pressure and heart rate is something that we would want to continue to check on because of the lisinopril and just to see if that heart rate is actually coming back to more of a baseline for her versus the higher heart rate that we've been seeing.
Hey,
So
there she
those
is.
so those are the steps that, really thinking about how one might look at a patient profile and the order, if you will, of steps that I tend to take as I'm going through them. So, Kevin, as we had discussed, I kind of put in a list of things, meds, match the diseases, check the labs and the timeliness of the medicines. Like, is it still issues? Any issues that the patient has currently? Thinking about side effects, ask questions, sleuth, recommend, monitor, and follow up. And I came up with the acronym of many meds cause a tumble, stumble, rumble, multiple falls, just to help remember all of that. So let's reduce all of this so that we can reduce the stumbling and rumbling and but the whole point of this whole issue is in the chart it says mechanical fall. And yeah, the person tripped, but think of all these things that increase the risk of tripping. The muscle weakness, the low sodium, low magnesium. Those are all things that can increase our risk of tripping and not being able to regain our step or and really cause us to tumble. So it wasn't even like she could like grab if her face went into the wall of the door jamb, like her hands did not go up, like that whole reaction time and things like that, the strength of her arms weren't strong enough to stop her. So we can say all that we want that it's mechanical, but there's so much that's going on in our bodies that result in the travesty of the fall, if you will. How poor is that patient's outcome going to be?
Yeah, I think really well said, Donna. And, really looking through your process of getting the medication list formalized and finalized first, I think is a very crucial first step that sometimes we mistake, because the reason why is we think we have the med list when we do not have the med list, and they are taking other PRNs and supplements and et cetera, et cetera, et cetera. So some of the things that I was thinking automatically is when you started going through the list, I'm thinking, well, did this individual need to take Benadryl for sleep? Do they consume alcohol? Right. And seeing a combination of those two way too often in the hospital, of that deadly combo of alcohol and a anticholinergic agent and or a
Mhm.
Benadryl sleep
Yes.
component just ends up being very problematic. And the other pieces I was really curious on, Donna, is my eyes were drawn very quickly to the lidocaine,
Mhm.
Tylenol at maximum doses, and oxycodone, for
Yeah.
her overall pain and how she was taking those doses, because I feel like we way too often think PRN seems so simple to say. And then when you
Mhm.
say it in Latin, it's not that bad with proronata. But when it
Mhm.
goes home with the patient, it becomes very complex on deciding
Mhm.
when to take things, timing things, putting them on the counter the way they have before, if they're using a med box or not. That's just a
Yeah.
new level of complexity to add on board that can get mixed up. And now all of a sudden your dose is more significant than you had originally thought.
Right.
One quick query from a clarifying standpoint. We talked about the hydrochlorothiazide and the potential for hypomagnesemia, but what was the blood pressure, Donna? What was she running, BP
Yeah, her
wise?
blood pressure was very normal. It was all, maybe 120s, maybe 130, over 70s, 80s. It was actually excellent. It was perfect for, there was nothing alarming at all. It was more or less the heart rate that was, like I said, higher than what it was originally on previous times. So yeah, so her blood pressure was actually really good, even for pain.
Oh, amazing. And then
Yeah,
what's another tidbit? Timing of fall. Like when during the day, like does that ever come into your mind too? When during the
absolutely.
day did she fall?
Yeah. And it was during the day.
Okay.
Um, her daughter was out doing errands and came home to her mother. So like afternoon doing errands, came home and saw her mom on the floor. So yeah. So another, you know, thing that obviously she didn't need the 24/7 care kind of thing. She was just she lives with her daughter and does her thing. And like they said, never had this type of fall before.
Got it. Interesting. And then was there any like recommendations? You know me, I'm always about the wearables. So any recommendations on either having at-home monitoring with like an RPM program going in place, or with having the individual wear a smartwatch or something else to be able to track their vitals?
Yeah. Actually, I did not see any record of that being suggested. So I'm going to say no, that wasn't talked about. I I caution a little bit with older adults, and I know it's great for them, but are
Mhm.
they able to use them, and does this buzz thing bother them, kind of thing. So I don't know if it was ever tried or not. I do know some, for example, some folks who tried to use the continuous blood glucose monitors, and they were just buzzing all the time. They couldn't like figure out how to take care of it, so it would end up being more anxiety ridden. So unless the older adult is really adept at being able to, work around, I think that we have to be a little bit careful about um, just about their ability to not have it bother them or cause anxiety.
Mhm.
So,
Yep.
but I think it's a great idea, and more people, as we know, I think we're going to see more elders using it, older adults, because
Sure.
we're more in the technology world. So I do see that being a movement. It's a great option.
Yeah, I think it's so interesting the amount of data that we can get on some of those patients where we have a mystery mechanical fall and being
Mm,
able to see what was going on with their rhythms and
absolutely.
or rates during the time or up to or afterwards, be able to see what their sleep quality was like overall, their activity during the day and some of those trackers.
Mhm.
And as you had pointed out already, with an A1C that was 6, I noticed that it was only metformin on there, so I wasn't worried about
Right.
hypoglycemia in a typical standpoint.
Hmm.
But it
Still.
still it still
Yeah,
does require the individuals to eat and consume calories, for their blood
absolutely.
sugar to play the
Yeah.
way to. And so there's some really interesting other like factors. But you did mention the blood glucose was fine when you measured it there,
Mhm.
and then also the A1C was, I mean, almost super optimal.
Right. Exactly.
So those are all really interesting tidbits. I think
Yeah.
there's one more I was going to ask you about. Oh, the phenofibrate. Like in general, Donna, when you're seeing the phenofibrate on board, is that usually an initial red flag for any patient just because that's been something that has been almost an old guard process? And then when you saw the age of 88, I guess the one thing to point out to all of our listeners out there,
Mhm.
I feel like that can be something really quickly that I've noticed young clinicians grab onto that, oh, they fell because they're old. Like they fell because they're 88 years old. And
Mhm.
that mentality is something that I think if we can get anything from this, just because you're old doesn't mean that you are going to fall,
Right.
in
Right.
general. And I think
Exactly.
there's some clarification there. But with the phenofibrate,
Yeah.
getting back to that question,
Yeah.
is that something that you're like, here's a red flag that something needs to be looked at with
Yeah.
this regimen because likely it's outdated?
Yeah. There are definitely meds that do that in my head. It's like, oh, they've been on this for a long time. And is it still necessary? What are their labs really like? So I do I do look at that and any other medication that you can just tell, like, oh my gosh, they've been on that for a really long time, because we just don't see that any longer.
Right.
So yes, I definitely, that was like the first med I wanted to look up when I saw this whole chart. So absolutely it was. And then when I saw like all these things that they were cautioning against with muscle weakness, I was like, oh, and there we go. So yeah, so it was really interesting. And then of course, being up against a statin, increasing the risk of that muscle weakness is actually a category D, for an interaction. So definitely a concern.
And the last question I have for you is we had your good friend Janet on the show way back. Actually, we need to have Janet on again sometime soon.
Yes.
But when you and Janet were having a fantastic conversation, the one thing that I'm thinking here, because we didn't have any just here's the etiology, like the point where we said this is it. Here's the aha
Mhm,
moment. And looking
mhm.
at this chart, a lot
Yeah,
of things that you mentioned were really weakness related, almost like
yeah.
it was something that was going to happen. And if the individual tripped or fell, they were unlikely to be able to sustain themselves in either balance or
Mhm,
mobility or strength to prevent a
mhm.
collision from happening.
Yeah,
And thankfully, no bone breaks here. But
right.
with that kind of recommendation, after this individual is leaving your care in your facility, what is the handoff so that there is strengthening exercises occurring or recommendations to mobility and just overall
Right.
dexterity?
Yeah. So, great point. And, it's funny you bring up Janet, because we've been talking about, people will go home or they're in the hospital short-term rehab, whatever it might be, and they have physical therapy, and then they're discharged from that service, right? But they still might not be completely rehabilitated to the point where they probably still need to continue exercise, but
Yeah.
how likely are they going to do that? And is it still the right exercises? Maybe it's just it's more balance that they need now, or so so when I'm talking to patients and I know that there's been a fall or a balance issue or something of some sort, I do often suggest Matter of Balance classes,
Cool.
which is a program that is evidence-based. Many senior centers all throughout the country offer Matter of Balance programs. It's typically an 8-week program, and it tends to be led by physical therapists, but I've also seen occupational therapists. But it doesn't even have to be one of them. I mean, it could be somebody else who's trained, who is running the course. But they talk about all these things that could be factors, and they actually do strength training and muscle training, balance training, every single class, and everyone gets homework that they have to do it each day, and they continue on for 8 weeks, and it's actually been proven to benefit folks and reduce falls, and it increases balance. So I always tell people, even though you might feel imbalanced right now, you can retrain your brain. You can become balanced. You have to work at it, and don't just say, "Oh, it's my age, I can't balance." You can retrain your brain to balance.
Wow.
So that is something that I try to encourage with folks. SAIL is another program. I forget exactly what it stands for, but it's about strength training for older adults. And trainers tend to be the ones who are educated in the SAIL program, again, evidence based. And it literally helps people with strength and balance. It's an excellent program as well. So, those are a couple of programs that can really benefit folks.
Mhm.
Um, the other thing that Jan and I talk about is how important it is to just have someone who is not necessarily a physical therapist, but maybe an in-home exercise or wellness coach of sorts, if you will, to actually help an individual to continue those exercises, to continue gaining strength after hospitalization, and to keep in check. So those are definitely things that are all very much worthwhile, Kevin. So thank you for bringing that up. It's super important.
Massive, because I know you and I have talked about it to a certain degree, but it's just so often that we have an individual has a fall, and either there is a prescribed DME, a durable medical equipment like a cane that ends up going into the household, or a 4-point cane. And unfortunately, like you were saying with balance training, those can be something to be able to recover from a given injury and help with balance for that period of time. But
Mhm.
I mean, unintended here, maybe it's intended, they can become a crutch, that they start to decrease the overall mobility of the individual. If
Absolutely.
they don't have that cane or that mobility assistive device, then they're more likely to fall again at a later period of time because they
Mhm.
haven't strengthened and they haven't improved their overall balance and level of dexterity. And so I think there's just lots of benefits to be cognizant of.
Yeah.
Sometimes we do need to train the body, and
Yeah.
it can and is often related to the drugs. It could be the magnesium
Mhm.
levels, or could have been the other medications that decrease some of that overall,
Yeah.
utilization of musculature. It could also be the oxycodone on board, or pain in general that was decreasing mobility. And so therefore there
Yeah.
was just less exposure to movement. But I think it's just something so essential when we're breaking down a chart just like you did, and
Mhm.
getting through all these recommendations, that those non-drug recommendations that you see so often
Yeah.
go overlooked, that you're plugging in. So I love that, James, so
Exactly.
much on that
Yeah.
side.
Yeah. So anyways, I know that it's been asked, like, how do I go about doing this? So I just figured we would do a case, a very benign case, and just kind of seeing, like, wow, really making a difference. Could literally half this list of medications for this patient. And, that's good in itself, right? So just being able to take less and feel better, and not have everything, just having to keep track of all of this, and pay for all of it.
Yeah, I think that for everybody that was listening and watching in, Donna made a really nice acronym. But if we can walk through it, I'll just click through the slides here, Donna.
Yeah. So the meds, right? We want to get the med list first. And then after that, we want to match the disease states. So these are all, you know, inclined to. So taking the first letter, we'll wrap it up at the end. But so the medication list is for meds, and or many meds. The match the disease is so now we're at many meds. Sorry, I'm kind of messing this up a little bit. And then the next one that we have is the findings, or what are the check the labs and the timelines and things like that. So that's more a C. And so many meds cause. So cause or findings, patient issues and side effects. So ask about the patient issues, and are there any patient issues or any side effects? So that's an A. And so we're looking at so many meds cause A, and then we're going to go to the next one. And we want to be thinking about the side effects and asking questions. So that is like the tumble, and then we want to sleuth. So that's stumble on top of that. And then the next one, we end up doing a recommendation, and that's a rumble. And then the last one is monitor and our follow up, and that's multiple falls. So we know that many meds cause a tumble, stumble, rumble, and multiple falls.
Love it. Love it. That's
We do
fantastic.
that.
All right. And thank you so much. We had a kind comment just pop in. Appreciate that, and glad you're able to attend with us. That's fantastic. Hope
Awesome.
all of you
Thank
guys had a wonderful learning experience, just like I did, like always with Donna. And if any other questions pop up, you guys let us know. Important things to always plug in is we have a wonderful author to our right here that you need to make sure you get Med Strong and take Donna's classes. They're over at RPH Ally. You can join RPH Ally through rphally.com, and you can go and find the Deprescribing channel to find more of Donna's wisdom. She was just start talking about breaking down some other elements and getting into assisted living facilities and how she's trying to help them consider the implications of medications in their facilities and write policies and procedures related to that. So absolutely love that. If you want to learn more, tune on in to what Donna is doing there. We did have a wonderful soiree. It feels like, I guess it's just been a little while ago, but it still is fresh in the mind. If you want to go and watch that soiree, we had 25, 26 sessions of different thought leaders throughout the country. So go in there and then plug that in and get some information. And then if you need to get a hold of us at all, we are over there at RPH Ally. Feel free to hit Donna up. And then next week, we will see you guys back here again. Donna, any things I forgot?
No, all excellent things. And just, let's keep deprescribing. Let's optimize people's meds.
Love it. All right. Good night, everybody.
Thanks, Kevin.